Thank you very much. I am going to stand up just because I feel like it'll give me a little more oomph. Um, I know. That, uh, we had these two amazing presentations with Diane Meyer and Dr. Rick Goldstein this morning, and the people they were taking care of. And honestly, if I could clone them, you wouldn't have to listen to my talk. But since we don't have that technology yet, I wanted to tell you a little about where things get started. So, as a young oncologist, I took care of a guy named Bill from a place very close to here who flew to Seattle for a stem cell transplant. One day, a couple of months after his transplant, he started to cough. He developed a chest x-ray that looked like this. I called a pulmonary fellow who said, "I'm tired of doing these consults." And I said, "Why?" And she said, "I hate it when people cry when I come in and introduce myself." Right, I mean, patients know what's happening, right? And I said, "Don't worry, he's a surgeon, he won't cry." That was only the first of the times when I was wrong. I then, a little later, went to see him with my attending physician after we got the diagnosis of CMV pneumonia, which at that time was basically fatal if you needed to be intubated. And went in to see the patient. We talked about what was going on, and the attending said, "Don't you want to try everything?" And the patient said, "Yes, of course I do." And so they intubated him. And I said later, "Does he really know what's going to happen?" And the attending said, "Well, we don't talk about that." He said, "It'll be okay." Honestly, that was what I learned to do as an oncologist. And that was standard practice at the time. And every day I'd go in there, and it wasn't okay. It was kind of torturous. And I learned that not only could you cry if you were a surgeon, you can cry while you're intubated. It was a horrible experience, and it left me feeling like, I don't know if I can keep practicing like that. So fast forward a couple of decades later, I saw recently a guy named Kenny with metastatic pancreas cancer. Also a really serious thing. This time I knew to talk to him a little differently. I said, "What's important to you?" And he said, "You know what? I really want to go home." He had finished his clinical trial of his first-line agent, and so we sent him home. And then a week later, I got this picture in my email, and he had been fishing, and that's what he wanted to do. And so he spent a whole bunch of time on the Snake River outside Clarkston, Idaho, while he could. And his family has these, amazing memories of hanging out with him in the water catching fish. Very different from my patient who was the surgeon who actually never made it home to Connecticut. And actually, I don't know what he wanted because I didn't know enough to ask, right? The problem I illustrated with my story as a young physician, sorry, thank you, Marion, is still present. How do physicians talk about values and goals now? I mean, you saw two masters here who taught themselves how to do it, right? Like we all taught ourselves how to do it. And, it takes a while. It probably took me 20 years to learn how to do this. And the question is can we afford to wait that long for the next generation of physicians? And of course, we can't. But the problem is it's still happening right now. This is the survey that Amy referred to that was funded by the Cambia Health Foundation, thank you, the California Healthcare Foundation, the John A. Hartford Foundation. 736 physicians in the United States earlier this year asked about what they thought about advanced care planning, right? So 99% of them thought it was important. 75% of them said, "It's my job." How many of them did it and billed Medicare? 14%. There is a huge disconnect between what doctors think they should be doing and what they actually do. Hear the words that doctors actually use. I mean, James has done a lot of research about this, but these happen to be from a study that I did of oncology fellows. And they say things like, "Do you want us to do CPR? I mean, pump on your chest like you might have seen on TV if your heart stops," right? So that's what happens if you have a rule that says, "We're going to pay you to do this," and you send an untrained physician in there to do it. This is what they're going to say, and it happens a lot right now. Then then the patient looks up in horror, and the physician will just keep talking because they get upset, and the best thing they know how to do is to just keep talking. And for physicians who don't know what to do with this look, this is a conversation stopper, right? And so this is what they say when you survey them later. Why didn't you talk about this? 66% of them said they didn't have time. 60% say they're not sure the time is right. 46% of them say they're unsure what to say, which is a little stunning. Like, I don't know how many of you have had a colonoscopy. Was your primary care physician unsure about how to explain a colonoscopy? Right? I mean, that just doesn't happen, right? It's crazy. But yet 2/3 of these people had no formal training, and that's why they don't know how to do it, because we didn't learn how to do it. There is a small number of us who figured out how to do it ourselves, and it's not disseminating very fast, right? How often do doctors now, oncologists, I'm going to pick on my tribe a little bit, how often do they use skills that are critical to overcoming barriers? And this is, of course, the study that James did at 2 big academic medical centers, the University of Pittsburgh and Duke. They probably do state-of-the-art cancer care in every respect. And these were patients with advanced cancer. They audio recorded all their conversations. It's the largest audio recording study ever done of doctors and patients with cancer, and the doctors made empathic statements in 11% of their conversations. That's 1 out of 10, right? And it's not even just about being nice, because there's other data that shows that if you, as a physician, respond to emotions for people, they retain more of the information you were trying to tell them. So this is not about just being nice. I mean, it is about being, compassionate, but it's also about doing your job and getting the information across, right? Physicians don't realize that they are not doing a good job, right? This is a study at the University of Washington of internal medicine residents, right? We're one of the top 10 programs in the country. Here's how they rated themselves. Here's how their patients rate them, right? I mean, if they were all well calibrated, all these dots should fall on this yellow line, and they're all over the place, right? This is the current state of training in communication, right? So what happens now is there's a lot of, quote, training that is residents watching PowerPoints that's basically ineffective. These doctors leave their training feeling like emotion is a threat, and what they do is they say the patients aren't ready, right? It's not okay. My back of the envelope calculation is that if you take patients with serious illness who are about to, die, or who are at risk of dying, that there are probably 2 million patients who are at risk this year. And actually, they're going to die by the end of the year, so there'll be 2 more million patients next year. And that's the magnitude of the problem we're facing with clinician training. This is the number of patients who are at risk every year because they don't have a clinician who can conduct a good conversation, or they have a clinician who does damage with their conversation, right? What we have learned, someone else mentioned this, I think Diane, is that communication is clearly a skill that you learn, right? My 2 stories were designed to illustrate that I learned to do this. I was not born learning how to talk to someone who had a serious illness. And the training that really works changes behavior. And after training, physicians use more empathy. They ask more questions to understand where patients are. They explore more values. These findings have been replicated over and over and over. And the Institute of Medicine in their report highlighted many of these studies. This training persists over time. It's not a one shot and it's gone kind of thing, because there is this self-reinforcing cycle where physicians connect with patients. They feel like they're doing the real work they're supposed to do. They keep using these skills. So this was a study from the UK where in a randomized study of attending oncologists, not trainees, the improvements in communication skill from a 3-day workshop persisted 12 months later, right? So this is a very worthwhile investment for clinicians. And I'm using physicians because the studies have been done with them, but clearly it's the same for nurse practitioners and other clinicians too. In our physicians actually like this training. I mean, in our study, we said, would you recommend it to your colleagues? And our oncology fellows said 95% positive, highly or very highly, right? So it's not necessarily something that you would have to subject them to. Once they get into it, they realize instantly how important it is. And the more skill they have, the more trust their patients have. Of course, right, this is another study of James's, a randomized trial of oncologists who were trained in a randomized way to be able to use empathy in a CD-ROM kind of application that drew on all the principles that we have learned in our face-to-face courses. The trained oncologists used more empathic skills, and their patients rated them with higher levels of trust. And actually, sorry? I know, the P is, I have the wrong, I was just looking at that because I realized I have the wrong P-value. I'm sorry, I'm missing an O, sorry. I know, I'm sorry. I'm breaking his heart, even though this is a huge study. Okay, I'm sorry. Here's the point about these trainings, though. The real point is these trainings were accessible through research studies only. So, right, so we had 1 million people call us up and go, how can I get into this? And we would go, sorry, it was for like 90 oncologists who were part of this research study, and we don't have a way of continuing it. Because of that, we decided to launch a nonprofit to be able to disseminate this more quickly. And so that's what we've been doing over the last few years. And this training is ready for prime time. Here's our website. You can watch James use these skills on our videos. This is an actual workshop that we did in Philadelphia. This workshop is like a flight simulator for a difficult conversation, right? You put the doctor in the hot seat. She is sitting over on the right. You have the doctor talk to an actor who plays a patient, who improvises like mad. This is not at all your usual medical student standardized patient case. And you have somebody who gives close feedback, right? So it's like when pilots learn to deal with difficult situations in their flight simulator, doctors learn to do it in this kind of workshop, right? And then we have these other fun things that induce people to be reminded, et cetera, et cetera. This is our iPhone app, and it's on Android too. And now we have, in the past 2 years, trainers who are teaching workshops, all over the country. This is the last 2 years of our trainers. And since we moved from just doing randomized studies to doing this 501c3, we've increased our ability to produce trainers more than tenfold, right? It turns out right now in the big world, there are really no incentives whatsoever for clinicians to actually undertake evidence-based training. They get maybe CME for it, but really they don't get anything. The current CMS, reimbursement for having a conversation doesn't have anything to do with actually doing a conversation that makes a difference. And that's one of the issues that I think this group could really address, right? And then finally, I just described what my experience was like when you're facing patients day after day, doing a crappy job and feeling like I don't want to do this anymore. And there is a little bit of data that shows that physicians who have had an interactive communication course have less burnout, even as they do a better job. And so I think there's a very important issue here related to the quadruple aim about clinician well-being and them connecting with their patients better. So here's the bottom line. There are a lot of patients at risk. The training really works. We're scaling it up. I think one of the huge things that could come from this kind of conference would be policies that foster a clinician workforce that really has the skills to put patients first in the way that you saw here, right? Those kinds of policies could be incentives for clinicians to invest in their own training because most of them didn't get it. It could be other ways to make access to these courses easier. And of course, I realize that, clinician training isn't the whole thing. It's not going to solve the entire problem. I mean, right, we still need to do work on the EMR. We still need to do work on how do physicians know which patients are highest at risk, right? Many of you in this room are working on those initiatives, and I am not saying that those are unimportant. I am simply saying that this clinician training issue is a centerpiece of the whole problem, and if we don't work on this, all the other system things will not take the place of this, right? And so if you do this kind of work, you know what happens, right? Here's Kenny. The other thing he wanted to do besides fish was play with his grandson, right? Vanessa wanted to paint. Here she is, 6 or 7 years into metastatic colon cancer, 2 years longer than the best case scenario quoted to her by her oncologist, me. Uh, Here is Taylene, who, as a music lover, was telling me about how she went to see Bruce Springsteen. I said, you were at a Bruce, anyway, she went to a Bruce Springsteen concert, and this is 4 surgeries into her metastatic appendix cancer, right? And then finally, here's Alan, who is a software engineer, is a couple of years into metastatic colon cancer, loves to hike, and this is what he's doing. He's with his German wife, Petra. They're in Florence. So there is a huge amount of life that's possible for our patients if we have the skills to ask them what's really important. And so I wanted to highlight this as one of the pieces that we need to pay attention to, even as we think about how to put patients first. Because if we don't have clinicians, if we don't have a workforce that can do that, it'll all fall apart. So imagine, you know, after the end of the day here, you go to Reagan to fly home. You're stopped in line getting into the plane because some guy ahead of you is trying to put some huge thing into the overhead compartment, right? How often does that happen? You're standing next to the pilot. You know, you start to make chit chat, and imagine if the pilot said, you know those flight simulators? I've never done that. My friend thought it was really good, but I don't really think I need it. What do you think? What would you say? Right, thank you.